Thank you, guys. I look at myself as more like a hype guy for this talk than anything else. It's kind of like why you should pay attention to all the other speakers. So these are the disclosures in 6, 5, 4, 3, 2. There we go. So what is foregut, right? So I think one of the areas is defining something before we say like what to do and why should we do it. But real simply, it's the distal esophagus to the ampulla of the duodenum. Some would say it maybe goes up a little higher than that. I think some foregut surgeons creep into more of the thoracic space, benign thoracic disease. But usually it's paraesophageal hernias, GERD, achalasia, gastroparesis, right? So we do have to take care of that patient population, and cancer and obesity. So obesity is going to come into play in this conversation a little bit. Why to get started is just as important as what to do to get started. So why to get started? So I'm going to talk about GLP-1s for a second. I think if you made it to the earlier lecture today about the interplay between GLP-1s and obesity, it's impressive. Somewhere in the United States, you're feeling something, somewhere either between a 5 to 40% decrease in bariatric numbers. So anyone in the audience who is a purely bariatric surgeon or does not do any foregut but is a bariatric surgeon? Confidence. Nobody? You're all foregut surgeons? If you're all foregut surgeons, you know most of this stuff. Any bariatric surgeons out there at all? There we go. I was like, so you're an interesting group, right? Because in the bariatric space, it's sleeves and bypass for GERD, but is there more, and is there a space where we can grow our practice? If our practices are under threat or there's decrease of patients, is there opportunity to transition a little bit? And we'll kind of leave you with a teaser there. Subspecialization versus general surgery. So right now there is no subspecialization. Foregut surgery is a fellowship. There's technically like less than 20 of those. There's only 9 that are actually both bariatric and foregut. So it's a really small, nuanced group of people that's getting trained. And really right now there's no credentialing behind it. So you can do 5 years of general surgery and do a redo paraesophageal hernia. Nothing stopping you, no credentials. Yet is that a complex operation? Yeah. And do you need to know the work behind it, the physiology? Of course. So this is where we're kind of left. Dr. Ketan and I we jokingly say we've got a road show around GERD, right? And we spend a lot of time talking to both foregut and bariatric surgeons, but the two groups are sometimes polarized in my opinion. Bariatric surgeons get GERD, we go right to bypass. Foregut surgeons get GERD, and wow, they go to physiology, they go to tests, right? And that's what we're going to learn about a little bit today. But as that bariatric market might come down a little bit, this group most likely will start to merge over here. Get a little bit better idea of what GERD is, how its interplay is with the LES. Are there options outside of just a bypass? And I think what we're going to end up is kind of this. We're going to get this really interesting group of both combined foregut and bariatric surgeons. So what I'd say to you is, to the bariatric surgeons in the group, this is what your programs look like, right? And these programs are very defined, right? They're centers of excellence. They've got points as you go through. We know exactly what they look like, and they're established based on standards. Is there a potential to do the same thing in the foregut space? Now, maybe those patients go through your bariatric program or there's a separate program for them, but is there a way to get calculated about it? Or instead of saying, okay, we've got a big paraesophageal hernia in clinic today, we're super excited. Is there a way to actually build a program around that patient? Something that looks at PPI trials. Do you manage that? Do you understand Bravo pH? Where are you with your esophagram, your high-resolution manometry? Do they get an endoscopy? And then what are the outcomes, right? Because we want them off their PPIs. So that leaves us now with how to get started in foregut and diagnostics. Before we jump in that, I want to leave you with one other thought, though. So we know that U.S. citizens, Americans, pretty much do not like to be on chronic medications. PPIs are a great example of that. I can't tell you, to the foregut group in the crowd, how many people came into your office in 2020 when all the PPI reports came out in the lay press. You know, a 20-year-old, 25-year-old would show up saying, I took a PPI, I want anti-reflux surgery. Whoa, no, that's not the message here. But people really come in to get off of PPIs. So as we move to the GLP-1s, one would only assume that there's a potential for those individuals to come back to the bariatric space. But in that interim, should we be looking at improving our practice and really merging those two worlds? So how to get started? First, you have to know the tests, and the stuff I'm going to put up right now will be highlighted by the other speakers, but I just want to give you a little bit of kind of a 10,000-foot view as what's to come. So high-resolution manometry. probably one of the most important tests in this space. It's going to give you the functionality, vigor, and the strength, really, of that esophagus. The other one it's used in combination a lot with is EndoFlip. So that's going to give you a different measurement, right? Distensibility, or how much that esophagus can actually open up. When we look at pH studies, this is a study everyone knows, right? Bravo pH, right? It's probably the workhorse to go to. And what you think about is it's usually 48 hours versus 96. I'm sure we'll hear more about this. But the one I want you to leave from, at least questioning, and how can it fit in, is this, impedance, right? So we always talk about acid, but is there something different too we need to look for? Bile reflux, or just regurgitation in general, and impedance can help us with that. Emptying studies are classically important, more so for morphology than it is like actual physiology. So here we can see an upper GI esophagram showing you, achalasia and a bird's beak, or a big paraesophageal hernia. Also, we need to understand gastric emptying studies, how they can be interpreted or even misinterpreted, right? So if you've got someone with that big paraesophageal hernia up there and a positive gastric emptying study, is that real, or is that just retained food? Is that real gastroparesis, or is that just retained in the non-draining fundus? And then we need to look at screening and surveillance. This is critical, right? Because we know these patients are at a risk for esophageal cancer. So Barrett's to low-grade, high-grade dysplasia than cancer. Right now, usually it's Seattle protocol, a whole bunch of biopsies, but we've seen this picture before. And this is where you end up with selection bias. The red dots are your biopsies. The darker area there is high-grade dysplasia. The lighter brown's low-grade dysplasia. All the biopsies are taken probably where the Barrett's is, so you miss the high-grade dysplasia. Is there something better? So I think Watts 3D became really popular. It's kind of where you take it down and you give brushings, right? And it'll look at those cells and kind of tell you if there's something different. But those are both still invasive. Either endoscopy, right, to get the biopsies, or you have to do endoscopy to get the brushings. It still goes down through a scope. It's not really a surveillance, right? Surveillance has to be affordable, and it's got to be easily tolerated by a patient. And really, if it's requiring anesthesia, it's not quite surveillance. Cologuard's a great example when it comes to colon and rectal cancer. There is this, so EsoGuard, right? It's something you can swallow. It inflates in the stomach, pulls back. You can do it in the office. Really, for a surgeon's office, it's a great thing, but maybe even more like ENT or primary care, but an incredible device to screen for additional pathology. So conclusions I'm going to leave you with for the next speakers to kind of go over. Foregut surgery is in the process of defining itself. That's both with the Fellowship Council, fellowships, but most likely will this come to credentialing within your hospital, could get there. It's prime for market growth in a shrinking bariatric market. The first step in any of this is understanding the pathophysiology. And then I would say don't celebrate those single, hiatal hernias that come in, but really relish and build your own bariatric or Foregut program. Thank you.